تيوصل لappraisal أو يوصل ل لنقطة أعلى من اللي هو فيها حاليًا، أو يكون في فرص بإنه يكون في عنده أي freelance job أو other jobs beside his own job أو الmain job لزيادة الدخل. ولكن الشيء الوحيد أو الشيء برضه المشترك اللي كان مع الكل أو معظمهم واللي الكل وقعنا فيها إنه كان في دايمًا شيء ناقص، كان في شيء دايمًا مش عم بيكمل أو في دايمًا directions غير صحيحة ما قدرت توصّلهم للcareer goal اللي هن رسموه أو الحلم خلّينا نقول اللي هن رسموه لنفسهم. طبعًا هالشي بيعود لأسباب كتيرة وأسباب عديدة، حأذكر البعض منها سريعًا ألا وهي following the trends. following the trends من دون ما أكون أنا محددة أهدافي أو عارفة أنا شو بدي بمجال العمل خاصةً بالhealthcare sector آآ دايمًا بيوصّلنا لمطرح ضبابي. in addition لأسباب أخرى متل الunclear goal لمّا باكون أنا مش محددة الgoal تاعي مضبوط وشوف أي course موجود وابدأ آخُد الcourses من دون تحديد مسار واضح، وتصديق كل شي بنشوفه على السوشيال ميديا أو كل خبرية بنشوفها على السوشيال ميديا. من هون إجت Klima Training Academy تتقول إنه Klima Training Academy is putting herself in its audience shoes. فنحن أي شي بClima Training Academy بنقوم فيه أو بنطلّعه أو بنحكي فيه من courses من training programs من career path قبل ما نطلّعه للعلن أو قبل ما يوصل to our audience كلنا بدون استثناء من رأس الهرم لأقل حدًا بيشتغل المؤسسة بيكون is putting himself be our audience shoes experiencing كل التفاصيل من الquality of ال learning methodology الexperience اللي بيمشي فيها المتدرب الjob opportunities أو للcareer goal اللي بيوصل له. قبل ما أقدّم الspeakers نحن اليوم إن شاء الله حنرفع الستار عن حقائق كتيرة عن الmedical coding خاصةً الmedical coding الأسترالي. الmedical coding lately هو منتشر وit's a need وit's a future والكل practicing أو عم يدرس أو عم بيشوف أشيا كتير عن الmedical coding ولكن في بعض الحقائق الغائبة عن أذهاننا. اليوم إن شاء الله نقدر من خلال our speakers الموجودين معانا دكتورة أماني شرف الدين ومسز هيدر جرين نقدر to cover all these aspects ونقدر فعلًا نرفع الستار عن الحقائق أو عن تفاصيل الميديكال كودينج الأسترالي. قبل ما نبدأ بintroducing my speakers I would like to ask our audience مين جديد على مجال الmedical coding؟ الجديد على المجال الmedical coding he can raise his hands بس لنشوف هل كلنا بنعرف we are involved أو بنعرف الmedical coding أو في معنا ناس مشتركين جداد على الfield. خلود، أوكي، حبيبة إيمان. أوكي، صارت المهمة شوي أصعب عند دكتورة أماني هلأ تعطينا توضيح مبسّط للناس اللي جداد عن الcoding. تمام، حأعطي introduction بس بسيطة عن our speakers. نحن معانا اليوم Mrs. Heather Crane. Mrs. Heather Crane is the CEO of eHealth Education in Australia. طبعًا مش حاقدر يعني أذكر كل الhistory لأنه ما شاء الله she has a very vast experience بموضوع الeducation والdesign والimplementation والdigital healthcare in addition لخبرتها الدولية والمحلية الطويلة بهالمجالات ومنها قادت طبعًا مشاريع عديدة برضه بالسعودية. ومعانا كمان دكتورة أماني شرف الدين she is the head of Klima Training Klima Medical Coding department وshe is an expert trainer well known بالسوق المصري والسعودي كمان عن الmedical coding الأمريكي الأسترالي وما شاء الله كمان كانت leading a mega project بما يخص الmedical coding الأسترالي. حأبدأ مع دكتورة أماني. نحن we will take this journey أو we will take this الحوار لمطرحين. من الجهة بالmarket المصري، ودكتورة أماني she will be involved أكتر، بما إنه هي اللي بتتعرّض أكتر للميث والfacts والأمور كلّياتها اللي هي بتكون بالسوق المصري. ومن الجهة الأسترالية اللي هن they are providing the Australian medical coding course. دكتورة أماني اتفضّلي. حابين نسمع منِّك intro أو تعريف عن الmedical coding taking into consideration إنه we have some audience أول مرّة يمكن بيتعرّضوا أو بيعرفوا عن الmedical coding.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. أولا بشكر حضرتك جدا مس هبة على الاستضافة النهاردة في الويبينار. الحقيقي يعني أنا سعيدة جدا بانضمامي ليكم، وأكيد شرف ليا أكون مع حضراتكم. وإن شاء الله يعني تكون ويبينار تعم بيها الفايدة على الجميع بإذن الله. اول حاجه بالنسبه للميديكال كودينج، على الرغم من ان زي ما حضرتك ذكرتي انه الميديكال كودينج من المجالات المنتشره في مصر في السنين الاخيره، وانه بقى يعني مش حاجه جديده، ولكن ستيل لسه بيجي سؤال او في ناس ما تعرفش يعني ايه ميديكال كودينج. الميديكال كودينج هو عمليه تحويل كل ما يخص المريض، سواء من تشخيصات أو procedures أو equipments أو investigation أو أي ما يخص المريض، إلى numerical أو alpha numerical codes. ده بشكل بسيط جدا. طيب ايه أهمية ده؟ يعني انا كده استفدت ايه، او المؤسسة الصحية او المنظمات والمنشآت الصحية استفادت ايه، وليه الكل دلوقتي بيحاول يعمل ده بشكل سريع وبشكل قوي؟ الحقيقة ان ده مهم جدا جدا. دلوقتي احنا دلوقتي بقينا في عصر التكنولوجي، وبقينا في عصر الدوكيومنتيشن، فبقى الميديكال كودينج هو اللي بيحقق لي الجول بتاعي ده، في انه يكون عندي proper documentation للبيشنت diagnosis وتريتمنت، يكون عندي electronic health record، بدل ما يكون عندي معاملات ورقية للبيشنت معرضة ان هي تضيع او تتلف. لا، دلوقتي بقى كل بيشنت ليه electronic health record اقدر ارجع له في اي وقت واستعين بيه. تالت حاجة، الميديكال كودينج مهم جدا بالنسبة للمنشآت والمنظمات الصحية، في ان هو بيضمن الكواليتي بتاعت الريمبرسمنت والبيلنج والريفينيو سايكل وكل ده. واخيرا ده كمان مهم جدا في الريسيرش والستاتستكس والديسيجن ميكنج على حتى مستوى الحكومات ومستوى الدول. وبالتالي الميديكال كودينج ما بقاش مجرد عملية عملية بسيطة أو عملية سهلة أو أي حد يقوم بيها. لأ، الميديكال كودينج بقى عملية أساسية ومهمة جدا جدا في كل الدول بشكل عام، لحد المؤسسات الصحية الصغيرة بشكل خاص.
شكرًا دكتورة أماني. دكتورة أماني، من في تداول فينا نقول دايمًا بنسمعه إنه الmedical coding it's an easy process. no need for learning أو no need for any يعني preparation. It's only a mapping, it's only a data entry و check and take the code and take the service from here and there and that's it. It's as يعني so it's so simple. هل هالشي صحيح والّا؟
بحط يعني زي ما الرول عندنا بيقول ان احنا put ourselves in our audience shoes، فانا دلوقتي بتوقع ان في ميديكال كودر اشتغل بجد بيسمع السؤال ده ومتخيلة رد فعله. حقيقي لا ابدا، العملية مش كده ابدا. عملية مهمة جدا، مش اي حد يقدر يعمل الميديكال كودينج. it's a process of learning و process of documentation، مش اي حد يقدر يعملها. مش اي حد مؤهل ليها، لا بالعكس، احنا علشان نقدر نقول ان ده ميديكال كودر نقدر نعتمد عليه، بيمر بمرحلة كبيرة جدا من الدراسة والتأهيل ومعرفة جايد لاينز ومعرفة ازاي يانلايز الدوكيومنتيشن اللي قدامه. فلا طبعا الموضوع فعلا محتاج دراسة ومحتاج حد يكون well learned يعني and well trained.
أوكي. أنا هانقل عند Mrs. Heather Green. Hello, good morning. We wake you up early today.
Good morning, Hiba. That's okay. Happy to be here.
We are sorry that we are talking in Arabic, but I'm sure that
That's
everything we
okay.
are talking about it, you already know.
I could kind of follow the topic a
Yeah.
little bit.
Okay, great. Heather, please, we would like you to introduce e-health education and tell us briefly about medical coding, the Australian medical coding.
Sure. E-health education was established in order to provide education in more innovative ways to be able to support building of skills in a whole range of different environments around the world. It was created by a group of people who've been working with digital health, electronic health records, for many, many years. So it's bringing together international experience of the best ways of training and building skills, because after all, training isn't just to get the certificate, it's to get the skills that you need. So e-health education was established for that reason. The Australian coding system, we have about 15 staff who are highly experienced health information managers and clinical coders. Most work in Australia, but we have many who work in other parts of the world as well. So if we look at the Australian clinical coding environment, we really talk about what is the process for clinical coding. And perhaps some of the things that are different to what you might assume are that the ICD-10 AM, the Australian coding system, with the Australian classification of health interventions for procedure coding, is used to express the diseases treated during a patient episode and the procedures done. Having said that, it is also designed so that it supports best clinical practice. In other words, the coding system in the inpatient environment, whether it be public or private, it's all the same in Australia in terms of coding. The inpatient coding is done where the patient's record is reviewed from beginning to end, not just a discharge summary. The clinical coder has to have significant experience and significant understanding of medicine. They have to be able to identify if a particular condition is a symptom, because we don't code the symptom, we code the disease. We code the reason the person came into hospital, and we code any specific complications. We don't just code everything that's wrong with the patient, because many of those things are not necessarily treated and therefore don't impact the cost of care. We don't code the symptoms because we can assume many of those symptoms are already present. So in order to do that, the coder has to have a good level of medical skill and knowledge in order to interpret what's in the record. We have to be able to understand whether the purpose of particular drugs. So we would look at the medication record. By looking at those records, we can identify what sorts of treatment might have been given to the patient. And if, for example, a patient has hypertension, we would only code that hypertension if the patient had their treatment altered during the stay for some reason, because that means there would have been extra attention given to that disease. So the objective of coding, when we're using the Australian clinical coding systems, is to identify the diseases that were treated or impacted the patient's stay. We code quite separately some chronic diseases. So they might well be coded, but they're not coded in a way that's going to impact funding. They are coded for public health purposes. It's also important to recognise that the Australian coding system has 5 components to it. There is an index for diseases and causes of injury. There is a tabular list of those things too. And the rules for coding with the Australian coding system are not guidelines. They are hard rules. If you don't apply those rules properly, your coding will be considered inaccurate. And when you're audited, which is done regularly in Australia, those incorrect codes, if they are making additional financial claims, are considered to be fraud. So we have to be very strict about exactly what is to be coded and what is not. And our clinical coders have to learn those things. So there are a whole range of specific rules that apply between the index, the tabular list, and the Australian coding standards. And when I talk about those standards, I'm not meaning a list of 5 or 6 things. There are hundreds and hundreds of standards. There is a lot to understand. So there's a lot to learn. Is that sufficient, Hiba?
Yeah, it's more than enough. It's
Right.
it lead us to one thing that to participate Australian medical coding, you have to learn the standards, and it is a journey of learning that you have to take it and then to take the pathway and can participate as medical coding.
Yeah.
Heather, I need you to answer me. Quickly and shortly about something I always hear about, that the Australian coding, it's only a one level process, or it is a one level course, that no need to take any other courses after that. What do you think?
Okay. I think that's a great question. Thanks, Hiba. Clinical coding is a very complicated activity. And as I'm sure you can imagine, the more complicated the patient's record, the harder it can be to get the coding right. So the way that the training has been designed, and the Australian government has a recognised training system for clinical coding that's been applied over many years, is to break it down into levels of learning. The first level covers how to just use the code books properly and how to apply the basic rules. That level of learning does not involve any really complicated medicine. The next level, we start to bring in more complicated clinical activities, more complicated anesthesias, more complicated diseases, more complicated causes of injury. And people can't learn everything at once. That's true of human nature. If you think of how did you learn mathematics? How did you learn anything? You learn the basics first, then you add more skills. The top layers of learning in coding involve records that have gone to intensive care, that have had multiple procedures, perhaps multiple injuries. We don't try to teach that type of complex coding when you first begin. We have to build the skills of learning. Sorry. So that's why we tend to teach some introductory basic learning of what is the process, let people practice that, then they come back and do the next level, and they build until they reach a point where they're a senior level coder who has the abilities to undertake a coding audit. That's kind of the top level of skill for clinical coding using the Australian coding system.
That's great. Also, you had a role in KSA implementing, as you know, Saudi Arabia is implementing the Australian coding with a little justification or customization with the Saudi billing system. And also there is a misunderstanding, and correct me if I am wrong. I received a lot of candidates telling me that the Saudi billing system, they were thinking that Saudi billing system, the list of the services with the prices, is the Australian coding. So Saudi billing system, the Australian coding, by default, it's so easy. It's only to pick up some codes from the list. I would like you to hear from you, since you were involved in updating with Silat in Saudi Arabia, the Saudi billing system. What is the truth, or what is the fact of using the Saudi billing system among the Australian system?
Sure, thanks, Hiba. Another very good question. The Australian classification of healthcare interventions focuses largely on inpatient activities, major procedures. The Saudi billing system is designed not only to take the Australian classification, it does use that, but it extends and makes it more complex. It covers not only inpatients, but detailed outpatient and non-admitted care activities. It is actually more complex than the Australian classification, than the ACHI codes. So it's going to take some extra learning. The way we view it is we teach ACHI first, then we add the extra complexities of SBS.
Okay. So we come here that if I need to work in KSA, and I have to take the Australian medical coding in addition to the Saudi billing system, so I can implement the guidelines in the proper way. I can code in a good manner.
Absolutely.
Yeah, I will go to Dr. Amani to ask you a question about كمان بيجينا كتير أسئلة عن الكورسز اللي هي الكونفرجن، يعني بما إنه حضرتك اختبرتي وخضتي مجال الكودينج الأمريكي، السيستم الأمريكي والسيستم الأسترالي. ناس كتير بتقلنا إنه إمتى حيكون في عندكم كورس فور كونفرجن من الأمريكي للأسترالي؟ فشو رأيك؟ نطلع الكورس؟
يلا خليني أقول it's a good question برضو، وأشكرك عليه يا مس هبة. حقيقي إنه خليني أقول قبل ما أجاوب عن السؤال ده، كلنا في مصر لحد فترة قصيرة جدا جدا كان بنتعامل مع النظام أو التكوين الأسترالي ده يعني like حاجة غامضة جدا. إحنا مش عارفين إيه جوه. حتى لو عندنا علم بالاي سي دي 10 اي ام، فباقي الجايد لاينز وباقي الاتشي والبروسيدورز والستاندرز احنا ما نعرفش عنها حاجه. يمكن برضو يصدق على كلامي ده زمايلي الكودرز اللي درسوا الامريكي وبدأوا يعرفوا في الاسترالي وبدأوا يخوضوا تجربتهم في الاسترالي. يقولوا إيه يعني، لو حتى دخلنا على اليوتيوب تلاقي كتير فيديوز عن المجال الامريكي والتكوين الامريكي والجايد لاينز، وممكن كمان يشرح ان ديتيلز. لكن الاسترالي لا، الاسترالي يعني غامض جدا، مختفي جدا، مش كتير عارفه بالذات في مصر. فكان فعلا كان في مقولة تقول إنه أنا ممكن أديك كورس يعمل لك كونفرجن من الأمريكي للأسترالي. أنت درست أمريكي، فتقدر دلوقتي بكل بساطة أديك شوية جايد لاينز أو أعرفك إيه الاختلافات وإيه تقدر تحول الأسترالي. الحقيقة ده مش حقيقي. أقدر أتكلم عن ده بعد دراستي للاتنين وبعد سيرتيفيكيشن في الاتنين. لأ، النظام الأمريكي totally different عن النظام الأسترالي. even الجايد لاينز والستاندرز هي different. حتى لو قلنا إن في تشابه، هيكون تشابه بنسبة 10%، مش أكتر. كل سيستم مختلف تماما، even شكل الأكواد وترتيبها مختلف. نقدر نقول إنه في تشابه في الاي سي دي 10 أكتر، يعني في فعلا تشابه في شكل الأكواد وترتيبها، لكن البروسيديرز مختلفة تماما، الستاندرز مختلفة تماما. ففكرة إنه أنا أحولك من الأمريكي للأسترالي بكورس، لا. انت درست امريكي، فانت درست امريكي واجتزت الامريكي، عايز استرالي، ابدا ادرس استرالي واجتاز الاسترالي. الاثنين لا يتعارضوا مع بعض ولا يتنافروا مع بعض. زي بالظبط ما اكون بتكلم عن طريق وطريق تاني، مش شرط ان اللي ده عشان طريق وده طريق فالاثنين يبقوا شبه بعض، لا. تاني حاجة انه النظام الاسترالي حقيقي محتاج لا دراسة، زي ما مس هيزر تفضلت وقالت، محتاج دراسة، محتاج معرفة. الليفلز بتاعته كتيرة. ف يعني الكونسبت ده ان انا اديك كونفرجن مش حقيقي. وان كان دراستي للامريكي ممكن تكون خلتني بعد كده، يعني اكيد واحد داخل امريكي دارس امريكي مش هيكون حد زي حد لسه ما درسش حاجة خالص، ولكن ما فيش حاجة اسمها conversion من أمريكي لأسترالي.
Thank you so much, Dr. Amani. Mrs. Heather, we were talking about the certification and the conversion between the American and the Australian system, but I have another question for you. Also, there is a lot of questions or a lot of requests comes to me saying that we will be learning the Australian coding with any entity or center who provide these courses, and then I can go through the final exam through HEMA or eHealth Education, and then I will be a certified medical coder. So tell us the true pathway. How can I get how can I be certified? What are the ways to be certified? The truth way, يعني.
Firstly, I would encourage anybody to do extra training. However, in order to get formal recognition of that training, using the Australian system, every training organisation, and that's eHealth Education, HIMA, anyone else, those organisations, we are required to have detailed evidence of your skills. Therefore, a simple short certification exam cannot cover all of the things we have to check that you can do. We have to check that you can get 5 records from every chapter of the code book at each skill level and code them perfectly. That's a big task. What we do at eHealth Education is we test that progressively so that you're doing, as you practice and then you get assessed, you are ticking off the skills we have to confirm. Whereas if you go and do something elsewhere, if you do it with eHealth Education, HIMA can recognise your qualifications because we are both registered training organisations, but we cannot recognise other groups who have not passed that level of requirement. The Australian government controls who can authenticate skill.
Okay. What about Klima Training Academy?
Well, if you go through Klima, you're using the eHealth education process, and any teachers that you are using have to be approved as appropriate to the registered training organisation requirements of the government. So that would meet our requirements. Absolutely. All the evidence that we need is collected through the training process that Klima use.
And that's what Klima Training Academy already have with the partnership
Yeah.
with health education. So also there is another, I know that you don't like this question, but I always, it's a continuous question. That some people think that HEMA certification is preferable more than e-health education.
That is a really common question. Absolutely. It does frustrate us a little bit because in Australia, if you want to be a training organisation that produces recognised training such as diplomas, formal graduate certificates, you have to be either a university or a registered training organisation. And all the registered training organisations have to follow the same list of skills. We have to confirm we have evidence of exactly the same skills. HIMA and eHealth education are the same. We are both registered training organisations. We are both following the same pathway. In fact, at the Health Information Management Conference last week, HIMA and eHealth education agreed to share some of our resources and work together on the advanced courses. The biggest difference, though, is that eHealth education includes training on SBS, which HIMA do not. And eHealth education uses online tooling to help you learn. eHealth education has some online material, but nowhere near as much as we have thousands and thousands of real patient records that HIMA don't have.
Let's talk about the tools, the tools
Yeah,
that
sure.
we use in e-health education, simulating the real coding word in a platform, sitting behind your screen, accessing thousands of files, real medical files, as if you are sitting in the hospital and taking the medical file of a patient and experience the coding process itself as if you are a medical coder in the working on job. So tell us also more about the tools you use.
Okay. When we first started, which was maybe 20 years ago, we used to teach coding with hard copies of records. We then moved to online and we scanned those records. But the problem was that it's very difficult to get enough records to give people practice and give people answers. So we developed an online learning tool called ERL, which stands for eHealth, EHR Online Learning. Sorry. And that tool was supported by the governments in Australia. The state governments have told hospitals to provide records to ERL. We de-identify them. We have the codes that are correct, all in the system, so you get very quick feedback, as well as your own tutor, if you're using this tool. The answers have been certified as correct by a whole panel of coding auditors. So you're not just learning one teacher's opinion of what the right code is, you're learning a audited and certified correct answer to the coding, as well as getting very quick feedback. This tool is now mandated in some of the states of Australia. If you're going to teach coding, you would use this tool. It's used in other countries around the world too. The government in Ireland use it for teaching ICD-10 AM 12th edition. Governments in other countries are using it. Slovenia is using it. So it is the most reliable tool for learning how to do clinical coding.
Yes, I already agree. I already experienced that before. There is another teasing question about the challenge tests. Some say that challenge test, if you pass a challenge test, it is equivalent to the certificate.
Mm-hmm.
Yeah.
challenge tests are used in some environments, but never a challenge test to get you your final certificate. Sometimes they have been used to allow you to skip the really basic learning and to start a little bit higher in the levels of learning. The reason we can't really apply a challenge test to give you the full certificate is because of the number of things we have to confirm, the number of skills, what are called the performance criteria. When we do an assessment, I said before, we have government regulations upon the training. You have to show that, for example, you can abstract data and apply all the different standards, and there are hundreds of them. If we were to produce a challenge test that tested and provided evidence of the enormously long list of skills we have to check, the challenge test would take as long as training you to do the whole course. So yes, we can do a challenge test to confirm that you have medical understanding or small parts of the course, yes, but not to issue a complete diploma. We are required to have detailed evidence of every individual skill and piece of knowledge that is tested during the whole program.
So also challenge test is to consider your skills and to consider which level you can
Start at. Absolutely.
Thank you, Heather. I will give you a rest and I will go to Dr. Amani to have some activities. Dr. Amani, I would like if you can introduce the activity of the skills and let's do the activity.
يعني خلينا يعني شوية نبعد عن الكلام ونخلي مشتركينا ومستمعينا يشاركوا معانا شوية. دلوقتي هنعرض لينك في الشاتنج بوكس، حضراتكم تقدروا تدخلوا على اللينك ده، هيظهر لحضراتكم السكيلز اللي المفروض من وجهة نظركم شايفينها مهمة تكون عند كل كودر منكم، سواء اللي بيسمعنا ميديكال كودر او لو لسه حد ما يعرفش عن الميديكال كودينج ولكن من خلال الكلام السابق يعتقد ايه هي السكيلز المهمة، وهنعمل ريتنج لكل سكيل من 1 ل5. احنا منتظرين الريزلتس والريبلايز بتاعتكم علشان نعمل لها اناليسيس. Okay.
Mrs. Heather, this activity, we are asking our audience about the skills that they think it should be available in the candidate if he is gonna take the medical coding career path. And we are checking the answers with the rating right now.
And while you're checking that, it might be worth pointing out that in Australia, you're not considered to be for a job in clinical coding until you get the whole diploma. In Australia, the full diploma, not the very top level, but just underneath that, is considered to be the entry level. Now, that's not so true in the Middle East, because you do outpatient coding, you do other sorts of coding where you can start a bit earlier. But that helps explain why we have so many levels as well, I suppose.
Yeah, in KSA and in Egypt, for the outsourcing, the Australian coding introductory, they can join the work. It's a little bit easy than Australia.
Yeah.
يعني الحمد لله ان احنا ما بنشتغلش في استراليا يا جماعة. والحمد لله ان احنا عندنا
أتمنى على
مصر
فكرة.
وعندنا السعودية. وان كان حقيقي برضو احنا الكودرز عندنا شاطرين، يعني خلينا نعتز بالكودرز بتاعنا. احنا الكودرز عندنا شاطرين. آه، عندنا شايفة الريتنج ما شاء الله بيتغير. واعتقد ان هو دلوقتي بقى ثابت. يعني from my point of view actually I will consider all of these skills are very important. I will rate them all of them 5. انه كل كودر، مش بس كل كودر، يعني كل موظف عموما في المجال الطبي والصحي، كل ما كان عنده سكيل من السكيلز دي، كل ما هو كان مفيد ليه هو بشكل شخصي أولا، ومفيد للمنظمة اللي هو بيشتغل معاها بشكل عام. فطبعا knowledge of medical terminology، ال differences between codes، ال attention to details ده مهم جدا جدا. يعني زي ما تفضلت مس هيدر وقالت انه انت لازم، مش احنا مش بس بنكود discharge summary، احنا مش بس بنبص، احنا يمكن برضو يصدقوا على كلامي زمايلنا. وزي ما تكرمت دكتور مس هبة وقالت انه احنا كنا في ميجا بروجكت، فعلا attention to details ده مهم جدا. ولما يجي لي تقارير تتخطى المئات من الصفحات، انا اكون قادر ان انا اعرف الديتيلنج واعرف افرق ما بين الميديكال ترمينولوجي باستخدام الجايد لاينز والستاندرز. ده مهم جدا. تايم مانجمنت مهم جدا جدا كميديكال كودر، علشان اقدر ابالانس شغلي وابالانس الحالات اللي انا بشتغلها within the time within the target. فده طبعا مهم. الكوميونيكيشن سكيلز، كمبيوتر سوفت وير، كمان النولج بالريامبرسمنت والانشورنس بروسيس، بالذات لو انت شغال مع شركات تأمين او شغال مع اوريدي مستشفيات بتتعامل مع شركات تأمين، لازم تبقى على علم ودراية بكل الرولز اللي بتخص المنطقة دي والبلد دي. فطبعا شكرا على مشاركتكم. واكيد كل الاجابات والريبلايز فاليد. وان كان كل ما زودنا السكيلز بتاعتنا وكل ما كانت كل السكيلز دي عندنا، فكل ما بقيت انا ميديكال كودر شاطر جدا.
شكرا دكتور أماني. أنا عايزة أسألك سؤال تاني عن موضوع الإمباكت of medical coding على ال patient care. Is there any impact ولا الموضوع الكودينج موضوع هو بس coding وخلاص، والموضوع ملوش أي تأثير على ال patient؟
طبعا يعني احنا يمكن لما ذكرنا أهمية الميديكال كودينج ذكرناها على نطاق المستشفيات والمؤسسات والحكومات اللي بتقوم بتطبيق هذا المجال أو هذه العملية. ولكن فعلا بالنسبة للبيشنت هل هو مهم؟ طبعا مهم. أنا ضمنت للبيشنت دوكيومنتيشن لكل حالاته، ضمنت للبيشنت دوكيومنتيشن لكل زياراته للمستشفى، ضمنت للبيشنت انه حصل له accurate documentation للحالات بتاعته، ما دخلتش تشخيص غلط، ما دخلتش وبالتالي ما اتبناش عليها تريتمنت غلط او بروسيدور غلط. ايفن لو هو كمان انتقل من مستشفى لمستشفى او من مكان لمكان، اتس accessible ان هو نقدر ندخل على الالكترونيك هيلث ريكورد بتاعه واقدر اعرف الهيستوري بتاعه. احنا لو بنتعامل مع بيشنت ما عندوش accessibility للهيستوري بتاعه، هو ممكن ينسى، هو ممكن ما يكونش عارف هو عنده ايه او امراض ايه او اخد ادويه ايه قبل كده. لكن لما انا اوفر له الكترونيك هيلث ريكورد، الدكتور مش محتاج يساله انت كنت عندك ايه قبل كده او كنت بتاخد ادويه ايه او علاجات ايه قبل كده. لا، هو يقدر يدخل على الالكترونيك هيلث ريكورد بتاعه ويشوف حالاته. كمان ضمنت له ان هو البيلنج سيستم والتامين بتاعه وايه يتغطى وايه لا وازاي يدفع، وان هو لا شركة التأمين تستغله ولا هو ياخد أكتر من حقه من شركة التأمين. فضمنت عدالة في كل حاجة تخص البيشنت. فأكشلي الموضوع مهم جدا من أول البيشنت لحد شركات التأمين لحد الحكومات لحد الدول. فالموضوع الكل منه مستفيد.
يس حتى بس يعني زيادة على الكلام اللي اتفضلتِ فيه على among الدول. حتى الدول قادرة تحط خطط وقائية للأمراض المتكررة والprevention وtreatment prevention قبل ما الأعداد تزيد، وكل ده بمساعدة الstatistical report اللي بتطلع من الmedical coding وتكرر الأمراض وتكرر نوعية الأمراض إيجاد علاجات وقائية ومعالجة الmost current أو الmost المتكررة الأمراض المتكررة among الدولة نفسها، خاصة بتغير الأمراض من دولة لدولة بحسب الموقع الجغرافي وother يعني مؤثرات أخرى. I will ask a question for both of you, Mrs. Heather and Amani, about AI is going to replace the medical coder. I see you
Who wants to
laughing.
go first? I am quite sure that AI has the potential to improve medical coding. But because of the complexity of the coding standards, because of the complexity and inconsistency of clinical documentation, AI can assist in some places, but the percentage of AI that seems to be able to deliver real outcomes for clinical coding is less than 5% of the projects that have been used around the world. That's the research is coming back telling us that. I think that Europe will be the first to achieve it because Europe is standardizing their health records. So they're getting their original data in their documentation consistent. But even then, you need to build a coding, a computer system that can understand all the coding rules, when you code something and when you don't. All of the symptoms of diseases, we can teach computers that, they can learn it. But I think you're talking at least 20 years away before it's seen widely.
It's a long time, so we
long
can
time.
all.
And by the time it does come out, we're going to need a lot of people who understand coding to write the rules for AI. So
Yeah,
the job will be there,
we'll
even
say
into
the history.
it will just change a little bit. That's what I'm seeing as I view it around the world.
دكتورة أماني, what do you think?
يعني أنا متفقة تماما مع رأي مس هيذر. actually ال AI دي حاجة جميلة، يعني دي حاجة جميلة جدا وبتساعدنا وهي بتساعدنا still، وأعتقد إن هي مش هتتخطى غير إن هي تساعدنا وإن إحنا نستخدمها، لكن إن هي تستبدلنا لا. وفي أي مجال، يعني يمكن تكون ال AI بدأت تخترق مجالات كتير وتستبدل فعلا بعض المجالات، لكن المجال اللي محتاج analysis ومحتاج detailing ومحتاج وزي ما قلنا في البداية الميديكال كودينج مش بس ان انا ادخل اكواد. الميديكال كودينج دي it's a process of communication between الكودر، ده هو حلقة الوصل اصلا ما بين الدكتور وما بين شركة التأمين وبين الريمبرسمنت سيستم. ازاي الاي اي حاجه سوليد، حاجه تديله داتا يحولها لارقام. هو لو في معلومه ناقصه او لو في مشكله في التقرير هو هيترجمها زي ما هي، او مش هيسأل ايه اللي ناقص، او مش هياخد باله من ايه المشكله اللي حاصله. يعني احنا عندنا لما كنا بنشتغل كان الكودر يطلع يقول ازاي هنا في ايرور في الميديكال دوكيومنتيشن، هنا انا محتاجه اعمل كويري للبروفايدر، هنا الداتا دي اصلا داخله حصل لها رونج انتري. فهنا الاي اي cannot detect this error. وطبعا ده برضو بناء على تجربة. هو كمساعد هو مساعد لطيف ومش في كل الأحيان، ولكن أبدا ما فيش خوف. أنا بالنسبة لي ويمكن برضو يصدق على كلامي زمايلي في الميديكال كودرز، لا ما فيش، يعني ما فيش حاجة دلوقتي حتى زي فعلا بنقول حتى على مستوى العقد القادم ما فيش حاجة كده.
Okay. I think Heather, there is a lot of tools that modernized that like Turbo Grouper, Turbo Coder. It is, what do you consider it? It is a tool that helps or to help the coder to find his way easily, or it is it will do the work for him.
Sure. There's two sort of levels of answers to that question. To code, you have to have the full code books, all 5 books, or you will not get the codes right. Now, Turbo Coder is an electronic version of the code books. It is much faster and easier to use than using the paper-based or PDF-based books. The Solventum encoder has the books included in it as well. But to learn to code, you must use the books. If you try and use the old 3M encoder, now called Solventum, you need to know the pathways. You need to know which words to put into the coder to get the right result. It's so easy to get a wrong result with a tool like Solventum if you don't know how to code, if you don't know the details. And that has been, there's been a lot of research into that over the years. I think that's, it's not really a disputed principle. You must learn to, the levels up to the diploma are taught using actual electronic or paper-based books. The books are the same no matter where you get them from. They are required to be the same. They are strictly controlled and released. Tools like groupers are an extra tool that apply after you've done your coding. So you do your coding, then you press the button for the software to send those codes and give you a DRG group. It is illegal in Australia to change your codes to get a higher DRG if there is not documentation in the record to support that change. You must apply the rules first, and you can only change it if there was something missing that the clinician eventually tells you about. So you need groupers, but it's more important that you can get the codes right, because if you get the codes right, the grouper will just do the job and you won't have to worry about it.
Okay, so we come to a conclusion that a tool without a knowledge, you will get a wrong codes. You have to have the book.
Yes,
Okay.
that's what the evidence tells us from years of research.
I have an unprepared question about physicians. Physicians think that they are the best medical coder, that they select the proper diagnosis code through checking, the drop list, which is listed in the hospital charge master list from the system, and this is the medical coding.
Mm-hmm. Again, this is something there's been a lot of research on all around the world. One of the problems with when clinicians code is they will often select the clinically correct code, but not put into the documentation the evidence that supports that code. Often clinicians will read the record and diagnose as they read. That is not permitted when you're coding. We have to stop clinicians doing that. I myself have read records and gone, I can tell this is a heart attack, even though the record didn't tell me it was a heart attack. But I'm not permitted to code heart attack unless the doctor treating the patient has actually written that. And of course, in today's world, electronic health records are not using ICD in the records. They're using SNOMED, because SNOMED is suitable for clinical practice. ICD is not. So as the world moves away from doctors and drop-down lists with ICD, it's even more important that the coders can do their job properly.
Yeah, great. So this came us with the conclusion that there is a demand for medical coders to count on them coding the files and coding the healthcare system. We've talked about the skills and the background that should be available in the candidate, so he can be enrolled in the medical coding courses, and said that he has to have a medical background. If we had a candidate that has no medical background, what other alternative or what other support courses that we can go through so he can take the same journey?
Okay. So those who don't have that detailed clinical knowledge, those people can take courses in the terminology and the medical science. We teach it from a coding perspective. So we teach the things particularly relevant to coding. We don't teach everything in medical science. That information is taught in an integrated way. So, for example, you would learn the terms for basic cancer, then the medical science for different sorts of cancers. For example, understanding the difference between metastases and a spread. They're two different ideas and they're coded very differently. So you have to understand those differences. We would teach those things and then teach the coding of cancer. We don't teach it all separately. It's way easier to learn it as a collaborated, integrated process.
And this is the most effective way. We already tried this before, and aligning the terminology and the science within the same subject is better than having each course separately. We are run of time and we are coming to our end of webinar. I was so excited for having and leading this discussion about medical coding. I will leave 5 minutes for the floor for audience if they have any question that it was not covered through our question and answer during this webinar. If someone has a question, please he can raise his hand and our speakers will be happy to answer their questions. It seems that we talked a lot. We covered all all the questions for our audience today. Okay. Okay, Dr. El-Shayma Sakna. Please, the admin, open the speaker for her.
هاي أنا كان عندي سؤال. أنا بصراحة دخلت الميتنج ده عشان أفهم علاقة الميديكال كودينج بالهيلث انفورماتكس. أنا خدت كورس قبل كده في الهيلث انفورماتكس، كذا كورس بصراحة يعني. بس بالحقيقة ما فيش أي كورس قال يعني في أي كورس اتطلب مننا إن احنا يبقى ناخد كورسات في الميديكال كودينج. ومن الناحية التانية أنا لاحظت إن أغلب الميديكال كودرز كلهم بياخدوا الكورس بتاع الأستراليان أو الأمريكان عشان هم شغالين في التأمين الصحي أو في التأمين عامة. فعايزة أفهم هو بس الميديكال كودينج ده ريليتد بس بالميديكال انشورنس، مش ريليتد بالهيلث انفورماتكس in general as a healthcare entity؟
دكتورة أماني، الجواب عندك أو عند Mrs. Heather? Mrs. Heather, the question said, what is the relation between the healthcare informatics and medical coding? Is there any relation, or we should take the medical coding, or the medical coding is only related for financial perspective?
I'm not sure I understand the question, but medical coding is done for a range of reasons. Finance is only one of those reasons. It is done to identify healthcare and health disease trends, so for public health purposes. It's used as a basis, as you know, for reimbursement. It's also used as a base for planning of healthcare services. but it is not used or should not be used it can be used for those purposes and reported in a patient's record. That's fine, but it is not the classification system that should be used for clinical care. It is because it is an aggregating system. It classifies things together. It doesn't. I'm trying to think of a simple way to explain the difference. In a health record, a doctor needs to be able to say exactly what the situation is at whatever level of detail is appropriate for that person's clinical care. ICD's rules for claiming and for public health reporting and statistical analysis mean that that doesn't suit what a clinician might need in their health record. That is why we have two major code systems used around the world, one for clinical care, the other for statistical purposes. ICD is the statistical purpose classification. SNOMED, the Standardized Nomenclature of Medicine, is the old name for that. SNOMED is the clinical terminology used in health records. And we have a lot of courses on SNOMED. I'm not going to go there now, but it is a very different type of code system used for very different purposes.
Thank you Heather. We wish إنه كنا قدرنا نغطي السؤال. طبعًا أنا حابة بس أشكر الجميع على الحضور واهتمامهم بالمعرفة أكتر عن الMedical Coding Training Programs أو Medical Coding Career Path. الMedical Coding Career Path أو الMedical Coding خاصةً نحن اليوم كنا عم نحكي عن الAustralian Medical Coding فتح أبواب كتيرة لفرص عمل كتيرة inside Egypt وinside سعودي أرابيا خاصةً للماركت المصري بعد ما صار في فورة أو ثورة باستقطاب الكانديديتس من مصر to outsource project سعودية من أكتر من جهة ولتزايد الطلب هيدا نحن قدرنا مع البارتنرشيب مع eHealth Education to provide this course بإيجيبت بaccessibility أسهل بطريق أوضح بcareer pathway أو learning pathway متكاملة. طبعًا اللي حابب يعرف تفاصيل الكورس أكتر ممكن حنترك أرقام التواصل أو حابب يعرف معلومات أكتر we didn't cover through our webinar. Please don't hesitate to send your inquiries. Okay, thank you so much for everyone. شكرا لحضوركم ويا رب يكون قدرنا نغطي تساؤلات وقدرنا فعلا نرفع ستار عن الأستراليان Medical Coding. Thank you Heather and sorry for waking up that's so early.
No problem. Thanks a lot. Bye everybody and good luck.
Thank you. السلام عليكم مع السلامة.